Welcome to today's discussion on bladder tuberculosis, a serious and often overlooked manifestation of tuberculosis. We'll delve into the intricacies of this disease, exploring its causes, how it develops, its prevalence, the telltale signs, diagnosis, treatment options, prevention strategies, and what the future holds in terms of research and prognosis. Let's embark on this informative journey together. Bladder tuberculosis, as the name suggests, is caused by the bacteria Mycobacterium tuberculosis. This is the same bacteria responsible for pulmonary tuberculosis, the more well-known form of the disease that primarily affects the lungs. Bladder TB is almost always secondary to a primary tuberculosis infection elsewhere in the body, most commonly in the lungs. The bacteria travel through the bloodstream or lymphatic system to the kidneys, and then descend through the ureters to infect the bladder. In rare cases, it can also occur as a result of direct extension from adjacent organs. The pathophysiology of bladder tuberculosis is a step-by-step process. First, the Mycobacterium tuberculosis bacteria reach the bladder. They then invade the bladder wall, initiating an inflammatory response. This inflammation leads to the formation of granulomas, which are collections of immune cells attempting to contain the infection. These granulomas can then ulcerate, causing damage to the bladder lining. Over time, this chronic inflammation and scarring can lead to fibrosis and a significant reduction in bladder capacity. In severe cases, the bladder may become severely contracted and dysfunctional, leading to a condition known as a thimble bladder. The ureters may also become scarred and obstructed, potentially leading to hydronephrosis, a swelling of the kidneys due to urine backup. While tuberculosis is a global health concern, bladder tuberculosis is relatively less common than pulmonary TB. The prevalence of bladder TB varies depending on the overall prevalence of tuberculosis in a given region. It is more commonly seen in areas with high rates of pulmonary tuberculosis, particularly in developing countries. People with weakened immune systems, such as those with HIV/AIDS, diabetes, or those undergoing immunosuppressive therapy, are at a higher risk of developing bladder tuberculosis. The symptoms of bladder tuberculosis can be quite varied and often mimic other bladder conditions, which can delay diagnosis. Common symptoms include frequent urination, urgency to urinate, and dysuria, which is painful urination. Hematuria or blood in the urine is also a frequent finding. In some cases, patients may experience flank pain due to kidney involvement. Systemic symptoms, such as fever, night sweats, and weight loss, may also be present, although they are more common in individuals with more widespread tuberculosis. Diagnosing bladder tuberculosis requires a comprehensive approach. A urine analysis is typically performed to look for red blood cells, white blood cells, and the presence of Mycobacterium tuberculosis. A urine culture can confirm the presence of the bacteria. However, it is important to note that the culture may be negative in some cases even if TB is present. Imaging studies, such as an intravenous pyelogram, NIVP, or a CT scan of the abdomen and pelvis, can help visualize the bladder, kidneys, and ureters and identify any abnormalities. Cystoscopy, a procedure where a thin tube with a camera is inserted into the bladder, allows for direct visualization of the bladder lining and the collection of biopsy samples for further examination. A biopsy is crucial to confirm the diagnosis and rule other conditions, such as bladder cancer. Bladder tuberculosis doesn't typically have distinct classifications or types in the same way some other diseases do. Its severity is usually determined by the extent of the infection and the degree of damage to the bladder. However, the presentation can vary from early, localized infection to advanced disease with significant bladder contracture and kidney involvement. The cornerstone of treatment for bladder tuberculosis is anti-tuberculosis medication. The standard regimen typically involves a combination of drugs, such as isoniazid, rifampin, pyrazinamide, and ethambutol, for a period of 6 to 9 months. The specific drugs and duration of treatment may vary depending on the severity of the infection and the patient's overall health. In some cases, surgical intervention may be necessary. This may involve ureteral reimplantation to correct ureteral strictures, bladder augmentation to increase bladder capacity, or in severe cases cystectomy, which is the removal of the bladder. Supportive care, such as pain management and hydration, is also important. Preventing bladder tuberculosis primarily involves preventing the initial tuberculosis infection. This includes early detection and treatment of pulmonary tuberculosis, as well as vaccination with the BCG vaccine in areas where TB is prevalent. Maintaining good hygiene practices, avoiding close contact with individuals who have active TB, and improving living conditions to reduce overcrowding can also help prevent the spread of tuberculosis. The prognosis for bladder tuberculosis is generally good with prompt diagnosis and appropriate treatment. However, delayed diagnosis and treatment can lead to significant complications, such as bladder contracture, hydronephrosis, and kidney damage. Recent research is focusing on developing more rapid and accurate diagnostic tests for tuberculosis, including drug-resistant strains. Studies are also exploring new anti-tuberculosis drugs and treatment regimens to improve outcomes and reduce the duration of therapy. Additionally, there is ongoing research into the role of the immune system in controlling tuberculosis infection, which could lead to the development of new immunotherapeutic strategies.